Sir Frederick Banting, the co-discoverer of insulin, on 14th of November. The theme for the World Diabetes Day 2021 to 2023 is Access to Diabetes Care, where Education to Protect Tomorrow is the theme for the second year of World Diabetes Day. Celebrating World Diabetes Day by Indian Pharmacy Graduates Association Women's Forum Kerala on November 12th. Respected fellow pharma community gathered here. First, let me introduce myself. It's me, Samiha Hassan, Managing Director, Med Academy. I feel much blessed to be the master of ceremony on the occasion of World Diabetes Day 2022. On behalf of IPGA-Women's Forum, Kerala, I welcome one and all for the national webinar on Access to Diabetes Care for Better Tomorrow. Let's start with the prayer for seeking blessings from Almighty. I invite Ms. Blessy H. Joseph, 5th semester B.Pharm, Chemist College of Pharmaceutical Science and Research, Ernakulam. Over to you, Blessy.
There shall be showers of blessing. This is the promise of love. There shall be seasons refreshing, sent from the Savior above. Showers of blessing, showers of blessings we need. Mercy drops round us are falling, but for the showers we plead. Showers of blessing, showers of blessings we need. Mercy drops round us are falling, but for the showers we plead.
Thank you, Blessy. Now, let's move to our program. Let's have a glorious beginning and a warm welcoming. It's my privilege to invite Dr. Lindsay Thampi. Lindsay Thampi, one of the most active, young, energetic professor, Department of Pharmaceutics from Chemist College of Pharmaceutical Sciences and Research, Ernakulam. With much respect, I invite you, ma'am, to welcome address. Over to you, ma'am.
Thank you, Samiha. A warm good morning to one and all. Respected dignitaries for today's session, fellow pharmacists, dear students, and all my delegates present here. Thank you to each and everyone for being here with us today. I am very much honored to welcome you to this national webinar based on the topic, Access to Diabetic Care for a Better Tomorrow, conducted by IPGA Women's Forum on the occasion of World Diabetes Day. IPGA organizes seminars consistently for pharma aspirants to gain information and to be effectively associated with the curriculum, which help the participants in achieving an excellent knowledge about the topic. It is indeed honor and privilege to welcome our chief guest, Dr. Kanchan Kohli, convener, IPGA Women's Forum, to glorify the event with her presence. It is an honor for all of us to have, she has taken her valuable time for joining this event. On behalf of IPGA Women's Forum, I welcome Dr. Sanju Devan, Director of Research and Development, Baxter Pharmaceuticals, Ahmedabad, Gujarat, for taking the time out from her busy schedule for delivering the keynote address. It's my pleasure to extend my warm and heartfelt welcome to a most renowned resource person of the scientific event, Mrs. Gobiga Krishnan, Head Academics, Jyoti Davis Diabetes Research Center, Trivandrum, and Dr. Veni R.K., Assistant Professor, Department of Psychology, Jyoti Nivas College, Bangalore, for accepting our invitation to share her valuable knowledge about the topic. I am very much pleased to welcome Dr. Kala D., former professor and head, College of Pharmaceutical Sciences, Government TD Medical College, Alappuzha, for rendering her wholehearted support for this event, as well as for contribution towards success of the event. I also welcome Mrs. Rashmi Chandran, Government Analyst, Drug Testing Laboratory, Koni, to this event for introducing our speakers. I also welcome Mrs. Ramya Gayatri S., Assistant Professor, Chemist College, Ernakulam, for moderating the session. A special welcome to Mrs. Samiha Hassan, Managing Director, Med Academy Thrissur, to be an important part of this session and make this session successful. My sincere welcome to our President, IPGA Kerala State Branch, Dr. Sadish Kumar CH, for his active guidance and support. On behalf of Organizing Committee, I welcome our General Secretary, Mr. Giri G, and Dr. Inshit MC, Executive Member, IPGA Kerala State Branch, and Vice President, IPGA Kerala, for the constant encouragement and helping hand towards IPGA Women's Forum. I also welcome Dr. Jeannie E.J., Professor, Department of Pharmacognosy, Delhi College of Pharmacy, Trivandrum, for delivering the vote of thanks. I would also welcome Dr. Mahalashmi R., IPGA Women's Forum State Coordinator, who inspired us to do the best and stand as a pillar of power. I ensure the webinar will be profitable and the next few hours will be fruitful for each and every one of you. So let us appreciate the effort of all the executive members of IPGA Women's Forum, Kerala State, for working hard to make this even a grand success. Once again, I welcome you all, the delegates from various sectors of pharma fraternity. Thank you all.
Thank you, ma'am. It's our blessing to have Dr. Kanchan Kohli as the chief guest for today's session. Dr. Kanchan Kohli is one of the backbone of IPGA. She is the convener for IPGA Women's Forum, professor and head of Pharmaceuticals, School of Pharmacy, New Delhi. With great honor, I welcome you, ma'am, to deliver the inaugural address. Over to you, ma'am. Kanchan, ma'am.
Ma'am, you are on mute.
Yeah. So thank you so much, Dr. Lindsay, just introducing nicely. Thank you for the team organizing such a lovely program that is on the diabetes. And really, we do have these nationwide or worldwide problem with diabetes. And the thing is how to manage it. So I really appreciate to have this particularly topic for today's program. And thank you for all organizing. Actually, little bit problem with this laptop is there. So just 1 minute, please. Hello.
Yes, ma'am, you are audible.
Yes, ma'am.
My screen is visible.
No.
Is that my screen is visible? Hello.
Yes,
No, ma'am.
Yes, ma'am.
Uh,
You are sharing, correct? That's what we are not able to see the screen. At least I'm not able to see. Others can confirm.
No, ma'am, the screen is not visible.
Hmm.
Is visible? Screen is
No.
visible?
No,
Yes.
no.
Screen is not visible, Shruti.
It's visible now.
Is it visible now? I think so. It is visible.
Yes, ma'am, it's visible.
Okay. So sorry for a little delay. I thank team of the Kerala branch, women branch, organizing such a lovely program that is on the diabetes, that is the access to diabetic care for better tomorrow. So as we know that today is the problems with the everybody, almost every family is facing this problem. So how we have to manage this diabetes, that's the big question. And I think it will be followed by Dr. Sanju from industrial point of view. And what I'm finding from the the large population point of view, that how we can manage this diabetes problem. So as we know, that's the diabetes mellitus is the just the chronic systemic disease. Just introduction, characterized by metabolic and vascular abnormalities, disorders of carbohydrate metabolism. So from here, what I am looking, if we will be having kind of the life management, which we people are sometimes because of the lack of time shortage and because of our busy schedule, we are not caring much about this problem. So we have to manage the life problem, and then only the nicely we can control it. Of course, we do need some little medication also with that. And the second point was the disorder of carbohydrate metabolism. So as the point indicates, there's the carbohydrate metabolism. So somehow if we just controlling the amount of the carbohydrate intake, maybe we can have the the problem in reducing this disorder. And especially nowadays, as the young population and people are conscious about this, and with they are not dependent on mainly on rice and wheat, we are taking the other grains also, like jawar, bajra, and we can say you are the food which is not having kind of the gluten in it. And those, with adding those materials in our diet, we can easily control over the problems of the, not easily, but we can control up to the certain extent. At least we will not come over to the insulin. We can survive just on the oral drugs. So this diabetes mellitus, as we know all, is characterized by glucosuria and hyperglycemia. So we'll be having the two forms, type 1 and type 2. So type 1 is the patient secretes through insulin, and type 2 is the patient secretes insufficient amount of insulin and insulin receptors. So we are having the diabetes mellitus symptoms like hyperglycemia, glucosuria, polyuria, polydipsia, polyphagia, and possibly itching. So fasting blood glucose is higher than 126. So what's the manifested by weight loss, weakness, increased frequency of infections? Without intervention, significant complications will ensure, include retinopathies, glaucoma, and neuropathies, cardiovascular disease. So we are having the classification of two types of diabetes. Type 1 usually has sudden onset. Of course, the autoimmune disorders associated with high incidence of complications requires exogenous insulin. 10% of those with diabetes are type 1. So type 2 is characterized by hyperglycemia and insulin resistance. and results from increased production of glucose by liver and decreased uptake of glucose in liver, muscle and fat cells. So with the symptoms of this, we can very well visualize when we can control these factors, definitely we can little bit control of the diabetes. And as a pharmacist, what our role should be there. Actually, we are organizing many seminars for these diabetes and many camps also nearby in the slum area, and where we are educating people just, I mean, how you can manage your diabetes, what it happens. But certainly it needs more education towards the people who are unaware of these, and because of unaware of factors, they may be kind of generating these kind of the problems. So here, what's the role of the pharmacist comes. As a pharmacist, we can give them instruction, then how they can manage and what's the medication they have to take. Sometimes because of the wrong medication also, they are not aware. They are, I mean, the poor people, they cannot manage to have the fee of the physician. So they themselves depends upon the factors. Somehow they are taking kind of the, we can say, the natural products sometimes, and just they are managing kind of the in uneducational fashion. So as a pharmacist, if we just give them right direction, definitely that will help our community and our pharmacy, our people, or our we can say the worldwide, it can be educated to people. So diabetes mellitus occurs at any age, gradual onset, less severe symptoms initially, easier to control. So it's very easy to control if we educate people and we educate ourselves also. So 90% of those with diabetes are type 2 multifactorial. So hypoglycemic drugs, actually we can have these drugs, and there are the number of the drugs which are available nowadays in the market. So my main emphasis is just to, I mean, the natural drugs or the plant material based drugs, which I'll be going little in detail, rather than, because all these are available in our we can say websites, also in our many times we are getting on Facebooks, WhatsApps. I mean, how we can control these the diabetes. These are the materials, YouTubes also. But really, I mean, I just compile those things in nice way so that we can give these material to people. And if they will be using kind of the natural materials, the thing will not become up to the stage where they can have these medicines, or they will be depend upon the medication. And particularly if it's not been controlled, then they have to come on the insulin. So we will be having the insulin also. And then the rapid acting insulin, of course, these are the many varieties, or the many, we can say, kind of the products which are available in the market, and they can have from the human sources directly also. And there are the ways to manufacture it. I mean, the different companies are producing in a different ways. So rather than going in that detail, because we are all from the pharma background, so today I've just given more emphasis on the natural products. So these will be having the short acting insulin, regular ileum. Then this may be given by different routes, what's the onset, and this all depends. Then we will be having the intermediate acting insulins. These are the products which are available in the market. Then we are having the long acting insulin. Then we are having the insulin mixture, which are available. So depending upon the condition of the patient and guidance of the physician, one can have the different kind of the formulation which are available. Then these are again the different formulation which are available. Then we are having the hyperglycemic drugs. So they are the mainly 5 types used to treat type 2 DM. We are having sulfonylurea, ureas. Then there are the many side effects of these medicine. So sulfonylureas, we are having the first generation, second generation. Now the third generation is also there. Then we are having the alpha glucosidase inhibitors. So Then we are having, these are the, the way to take it. So take it the beginning of each meal. That's the alpha glucoside inhibitors can cause bloating and diarrhea. Sir, we are having the bigonides. There's the metformin is the most commonly used, and at the initial level, the physicians are mainly giving this drug, this the metformin, as compared to the other drugs. They may be safe one to use, or we can say it's comparatively cheap also affordable. So that's why the initial beginning is being started with the metformin tablets, and I think Dr. Sanju will be telling us more in detail from industrial point of view. So these are, the many side effects are there. Ultimately, sometimes it happens, so the renal function failure is also there. Then as we know, kind of the eye blindness is also there because of the we can say the continuous use of these drugs, or in the long run of the diabetes, these symptoms may occur. So it is affecting, all these drugs are affecting the liver. So our first thing is how we can protect our liver in case of when we are taking the anti-diabetic or any other drugs also, kind of the anti-inflammatory drugs. Our main antidepressant drugs, our main aim is how we can protect our liver. And many of our herbal formulations, they are not affecting liver in that way. So even we can have some of our drugs with which we call as the nutraceuticals now, and mainly because nutraceuticals, they are mainly helping us for the managing our life. And along with that, if you will be having the suitable nutraceuticals, then somehow the life management could be in a better way as compared if we are not having kind of the liver protective drugs also. So next classification is just, we can say, you're the meglitinidase, and we are having these drugs which are available in the market, and as a pharmacist we are aware of these. Then we are having the mode of action of different anti-diabetic plant drugs. So I have just selected I have given the emphasis on the plant drugs. Of course, we cannot say that immediately we can control the diabetes with the plant drugs alone, but at least the life management could be there. And after sometimes our hello. So after sometimes the life could be managed in a proper way, and maybe the day will come that we need not to depend upon the synthetic drugs. Maybe our problem could be solved with our natural drugs, or the combination of the natural drugs, because our plant drugs also acting in a different way, and some are, as we know, the plant drugs just acting like insulin. So we can depend upon these plants, or we can mix these plants. Initially, we can start with the other plant materials, and afterwards we can have the combination of the plant material, and which can be given in a good way. So the plant drugs acting like insulin or producing insulin mimic effect, that's the eagle marmolis, and this is a very common, which we call as the bale also, and which is the very, we can say, cheap drug, and easily available and affordable. So many of our plant material which are just simply affordable. So why can't we begin with these materials, and afterwards, depending upon the patient condition, and maybe alone we cannot survive, and after sometimes trying with these drugs, and we can look after to the other drugs also along with that. So the plant drugs, first is the acting like insulin or producing insulin mimic effects. That's the one category. And the second category is the plant drugs increasing insulin secretion released from beta cells. So that is the cytillus colokinesis, ficus, Bengalis, and these are the drugs. I mean, these are the plant materials which are available in India only. I mean, we need not to import it. So Allium cepa, then Allium stiva, these are the various species of the garlic, we can say. Then Ocimum centrum, we were having the various species of these, allobarbitans, Nigeria stimum. So these are the, I mean, the easily available drugs, or we can say these are the kitchen drugs which are available. And why can't we start it from the kitchen itself also? So third category comes under the category of the plant drugs with possible action of regeneration or repair of beta islet of Langerhans. So it contains the hello. So plant drugs with the possible action of regeneration, repair of beta islets of Langerhans, and that is the Petrocarpus marxism and Gymnia silisa. Excuse me, Dr. Mahalakshmi, I'm receiving your WhatsApp calls. Is there anything which has to be? Hello?
So, ma'am, I think in the interest of time, probably
Okay.
she wants to say that the time. Yeah.
I'm just winding up.
Okay. Thank you.
So plant drugs with possible action of regeneration, repair of beta islet of Langerhans. So these are the plant materials. Then we are having the another category. There's the plant drugs which delay glucose absorption from GIT. So these are the, I mean, the mentioned drugs are there, plant materials are there. Next category, we are having the plant drugs showing alpha amylase and alpha glucosides inhibitory effect. So I have divided the plant material according to the what the synthetic drugs being divided. And the sixth category is the plant drugs modifying glucose utilization. So these are, again, we can say you're the kitchen drugs, and the list of scientifically investigated medicinal plants which been mentioned and how they are acting and which part been used. I've categorized it similar way, other category. Then the anti-diabetic herbal drugs and polyherbal formulation used for diabetes. So depending upon the condition of the patients, we can mix the plant materials, the different plants of the category which I have shown, the 5 categories, and we can administer these plant materials, or we can advise people to take these plant material so that their diabetes could be controlled. And these are the some, we can say, the herbal formulation which are available in the market from the different manufacturers like Himalaya. These are the materials which are, or these are the products which are available from Himalayas, Patanjali, and other, I mean, the markets. So I mean, this is the little introduction which I wanted to give. I mean, here, just conclusion sake, I must say that instead of starting with initially at the level of, we can say, when we came to know that our glucose level is going to be increased by the we can say you're the diagnostic test, then immediately we can start with the plant material so that it can be controllable and our blood glucose level should not go very high. So thank you so much giving me time, and thank you for team organizing this lovely topic on the lovely session or the needed session, that is the World Diabetes Day. And today I'm receiving the WhatsApp message, today is the pneumonia days are also there, and people are giving how to control the pneumonia also along with. So we are having the 2 diabetes day also and pneumonia days also. So with these remarks, I thank all for patience listening, and I really thankful to organizing committee for organizing this session and inviting me as a chief guest to inaugurate this session. Thank you so much.
Thank you, ma'am, for giving us such a simple and valuable information about diabetes in a more simplest way. Thank you, ma'am. Next, it's my pleasure to invite Dr. Sanju Dhawan, former South Zone Coordinator, IPGA Women's Forum, Director of Research and Development, Baxter Pharmaceuticals, Ahmedabad, who deserves special recognition in this event. She was the woman who was behind the formation of IPGA Women's Forum Kerala. With much respect, I invite you, ma'am, for the keynote address. Over to you, Sanju, ma'am.
So first of all, very good morning to each one of you who is in this, webinar. And I take this opportunity to really applaud the efforts of IPGA Women Forum Kerala, Mahalakshmi, who is leading and who has been keeping the passion alive for having these kind of webinars, seminars, which are beneficial for each one of us. And the other thing I wanted to take this opportunity to say this also, that Mahalakshmi and this team of women is able to do so because their leadership at IPGA Kerala is enabling them to do that, empowering them to do that. I'm so glad that, see, look at when this seminar is there. I can see the president's Dr. Satish, I can see Nishit, I can see Dilip, I can see many people over here who are there. They don't have any session over here, but then they are there for the moral support of these all women. So I think thank you very much for the leadership team at IPGA who are enabling these women to do. And I know that when we had started this South, IPGA forum, we used to see that in IPGA Women Forum only 10 participants, 20 participants, and 30 participants. I'm so glad to see today that at this point of time we have 79 participants. So I think that shows that perseverance pays. And I really encourage all these women who are there, Limsi, Guinea, and there are many more, joining. It's not that the IPGA Kerala South Forum is limited to only those 4 or 5 handful of names, but then there are many people who are joining, and that's the momentum, honestly, which I believe Mahalakshmi and IPGA Kerala Forum leadership team is bringing. So I really wanted to say thank you to all of you for keeping that passion alive. So my session is a very, very general one. And thank you to Kanchan ma'am, who is here today to, she told us about all those, I will say molecules which are available for the treatment. And I will say that it had been a big challenge for everyone. If you see insulin, it has been there for 60, 70 years, but there has been no oral formulation of insulin yet. People tried to make the nasal formulation of insulin, but I know that Pfizer was involved into it. There was one, Exubera, which was a nasal formulation of insulin, but it did not clear in the clinical trials, and it was a major loss for companies like Pfizer. So there has been continuous research which is going on for number of molecules. There are number of treatments which are available. Having said that, there are number of treatments available, I will say there is no cure available. There is no cure. I'm saying is cure because there is nothing that you take and after that you say that I am no more diabetic. So basically, you there are treatments available, but there is no cure as such, which will say that you don't have diabetic now. And I just wanted to tell you the numbers which are there in India. If you see, we have 1.3 billion people, and out of 1.3 billion people, there are 75 million diabetic patients. So you can see out of these 1.375 million are diabetic. There are 200 million, pre-diabetics which are there. And India is known as the diabetes capital of the world. Having said that, 75 million and 200 million pre-diabetics, it is very, very difficult to find out because many of the times people are not aware of whether they are diabetic or not because they do not undergo tests. So that's where the challenge with India lies. And my keynote address over here will be where we are, where we want to go. And I'm just telling you that where we are with these 1.3 billion total people, 75 million diabetic patients, 200 million pre-diabetics, and our market. So in 2021, if you look at the number of molecules which are being sold in India, are 17 billion. That is in 2022, 2021. And the projection is that this number will go to 60 billion US dollars in next 10 years. So you can see that that shows the seriousness of this problem, that how, where are we heading basically. And if you see, there is a study which says that an Indian spends about 11,000 rupees annually on type 2 diabetes. It's just an average, not, based on the data which is available. And when people, every study also says that when below 30 years, people spend about 6,000 rupees per year, while as people become more than 45 or 50, they spend about 17,000. Why I'm bringing these numbers is that, the study also says that most of the diabetic people are from low and middle income, and 35% of them have got about 20,000 rupees per income. So you can see that the amount of money which general low income people are spending onto their diabetes treatment. And as I said, there's no cure available. You start taking medicines, you just keep on taking your medicines for forever in life. And many of us have, Kanchan ma'am rightly said that many of us have got family members, our parents, our relatives, whom we have seen that they have first they are pre-diabetic, then they are diabetic. As they continue living with diabetic for 20-30 years, then it brings a lot of complications. For some people it is their kidneys who are impacted, for some people it is their eyes, some people it is brain, and so on basically. So the ultimately after 2 or 3 decades, and I'm just sharing my own example, where I have seen my parents, my in-laws, that after 2 or 3 decades, then they keep on struggling with the complications of this. So looking into this, this is where we are, where we have fair idea of where we are heading, how much market will be there, how many people will be there. And it is going to be unaffordable for people. It is going to be unaffordable for people. Having said that, so what kind of care, if you see Indian government, other agencies are making, is that we want to turn around this capital, who is the diabetes capital, to a diabetic care capital of the world basically. I think that's where the objective of India is. And I again I will say that overall diabetes can be divided into three pieces. One is your prevention, because there is no cure, so how you can prevent it. And one, if people have that disease, then how you can manage it and control it. I think the whole treatment, whole cure revolves around how to prevent it, and in case you get it, then how to manage it and how to control it. And I will spend some time on to how to prevent it. Is that how we can prevent it, is that it's very general, that as I said, that half of the people with diabetes, they remain undetected. And people come to know only when the complications arise, and by that time it's too late. So people have to prevent it by screening it from different perspective. And one of the other thing is that diabetes is not, in the initial stages, diabetes is not just like a disease where you have an infection, where you have this fever, where you come to know from your body itself that you are in a pre-diabetic stage, or you need to take some of the medicines. You only come to know when, most of the time, in rural India, people come to know when their kidneys or when their other things are impacted. That's for the reason because they never undergo the screening from time to time for several years, and that's the reason they are not able to find it out. So the awareness is low, which needs to be addressed. Those are few things people need to address. And the other thing is there, in India, the average glycated hemoglobin is 9%, which is 2% more than the international figures which are there. That shows that in India there is low awareness, and people are not aware of the diagnostics test, where they should get the diagnostic test. They should get their glycated hemoglobin tested in order to see what kind of treatment, whether they are diabetic, pre-diabetic, at risk, not at risk, or they need to do something. So I think those are few things which I would pay attention to, that how you can prevent it. And if you see there are WHO guidelines, there are India guidelines, there are many other guidelines which say that people who are younger than 45 and they are overweight or obese, they should have those screening tests. Or anyone who has a risk factor. Risk factor means that your father, your mother, or your siblings have diabetes, then it becomes more and more risk. If you have this in the family history, you become more and more risky. So if you are below 45, you are overweight, obese, or you have a risk factor, you should screen yourself from time to time, 6 months to 1 year. And those women who had those gestational diabetes during pregnancy, they are also recommended to get them screened from time to time. And people who are pre-diabetics, in the range of their glycated hemoglobin in the range of pre-diabetics, they have to get themselves tested. Children who are overweight or obese, they also have to get themselves tested. So basically, if this is the first piece where we spend a lot of time, so that we do not reach to a stage, or even if we reach, the probably in many of the cases it is impossible that we will not reach there. We will reach there at a certain age probably, but I will suggest that that can be delayed. That can be delayed by few tips which I wanted to give this, that manage your weight. If you are able to manage your weight, have a physical active life, go for yoga or any other things, eat healthy plant foods, eat healthy fats, and skip fat diets, and then make healthier choices. In many of the cases, we have there are so many, if you would see that there is cult fit, there are many other diet programs which are available in the market. I would suggest that when you take any one of these, food is a very, very important factor in your life. And whenever you go for any kind of, these diet programs, please look at the research which these people have done, and do your own research. And also consult your doctors. Once you are diabetic or once you are pre-diabetic, what kind of drug will be used for you? You consult a physician. They will get you tested for a certain diagnosis test, and based on that, you will basically be taking the treatment. So always keep a physician on board for you if you are a pre-diabetic or if you are a diabetic. And the other thing I wanted to say is another risk factor which I have seen in the families is the glycemic control. Sometimes, our parents, our relatives, they take the medicine and they do not take appropriate diet, and their sugar goes down, they fall, and then there is impact onto the brain. Probably these are some of the things I really wanted to say, that to look around. And I wanted to say that uh, we know that the problem exists, we know where are we heading, but at the same time we can control what we can control, and that prevention is the one thing which we can control. And then later on, making ourselves aware of, educate ourselves, educate our relatives about those all these things which can lead to complications, we can help them. I'm sure people who are here, they belong to pharma field, but at the same time, even if we are from pharma, probably we look at how to prevent it, how to control it, and how to manage it. I will say, if people have diabetes, don't be panic. There are people who have been living with diabetes for 50 years after the diagnosis. Even with people, I have seen people with diabetic living up to 95 or 100 years, because they manage their medicines, they control their glycemic control. The important piece is that how can your blood glucose level be in control, not higher, not lower, because both of the sides have got a lot of impact. With that, I really look forward to the speakers today, what we are going to educate us. And thank you very much once again, Mahalakshmi, for inviting me, and this team, who has been doing a fabulous job. And thank you to all the speakers who will be educating and making us aware of you know about diabetes, so that we are able to help ourselves, we are able to help our family members, and we are able to help other people around us. Thank you.
Thank you, ma'am. Thank you, ma'am, for the motivational words. And as at this moment, I remember a proverb: prevention is better than cure. As your words motivated and conveyed more points on how pharmacy professional could educate every individuals, including the diabetes patients and other people too. Thank you, ma'am. Here we start our session. The campaign focuses on the need for better access for quality diabetes education for health professionals and people living with diabetes. It helps diabetes patients to manage their disease and be as healthy as possible. As said by Brian Adams, trying to manage diabetes is hard because if you don't, there are consequences you will have to face or deal with later in life. A warm welcome to our beloved speakers of this session, Mrs. Gopika Krishnan GR and Dr. Veni RK. It's my privilege to invite the moderator of this session, Mrs. Remya Gayatri S., one of the most enthusiastic, young, and active women in IPGA Women's Forum. She is working as an assistant professor in Chemist College of Pharmaceutical Science and Research, Ernakulam, under Department of Pharmacy Practice. With much respect, I welcome you, ma'am, for the moderation of the session. Over to you, ma'am.
Thank you, Sameha ma'am. Now I would like to request Mrs. Rashmi Chandran, Government Drug Analyst, Drug Testing Laboratory, Koni, Kerala, for the introduction of the speakers.
Thank you, Ramya. I'm myself Rashmi Chandran. I'm an analyst grade 3 of Drug Testing Laboratory, Koni. And I would like to thank you, show thanks to Dr. Mahalakshmi for providing me this opportunity to introduce our speakers. And the first speaker, Gopika Krishnan GR. She scored her B.Pharm degree in our College of Pharmaceutical Science, Medical College, Tiruvananthapuram, and had MBA and MSc in Clinical Research and Regulatory Affairs and medical paper writing. She is head and academic of Jyoti Diabetes in Tiruvananthapuram. She is an alumna of College of Pharmaceutical Science, Government Medical College, Tiruvananthapuram. Presented original research papers at European Association for Study of Diabetes, EASD, and American Diabetic Association, and IDF, the International Diabetes Federation, ATTD, the Advanced Technologies and the Treatment for Diabetes. She is an invited speaker at the International Diabetes Federation Abu Dhabi and speaker at the Diabetes Educator section at the ADA Orlando and at various national and international forums. And she is a certified insulin pump educator, and I wholeheartedly welcome as a speaker, and I request you to take over the section. Thank you.
Thank you, Rashmi ma'am, for the kind introduction. Am I audible?
Yes, ma'am, you are.
Thank you. And good afternoon, respected dignitaries, my teachers and friends. First of all, let me thank Indian Pharmacy Graduates Association and Women's Forum Kerala for providing me this opportunity. And I would also like to thank Dr. Mahalakshmi Chechi for giving me this opportunity. Thank you, Chechi. So without much ado, shall I share the slides? Yeah, is it visible now?
Yes, ma'am.
Okay, yeah, thank you. So I am given the task of discussing the newer therapies and technologies in the management of diabetes. So any discussion about diabetes would not be complete without presenting the International Diabetes Federation Atlas. So which states that an estimated 537 million adults aged 20 to 79 years are currently living with diabetes, and India is second only to China in terms of the numbers. We have 74.2 million people living with diabetes as of now. So broadly looking into the classification of diabetes, we have type 1, type 2 diabetes, gestational diabetes, mellitus, and some specific types of diabetes. So type 1 happens due to autoimmune beta cell destruction, there is absolute insulin deficiency. And in type 2 diabetes, there is progressive loss of beta cell secretion in the background of insulin resistance. And we have gestational diabetes mellitus, where diabetes is diagnosed in the second or third trimester of pregnancy. And we also have some specific types of diabetes, such as monogenic diabetes syndromes, such as the neonatal diabetes and maturity onset diabetes of the young, which is called MODY. So let me minimize. So, and we also have the disease of the exocrine pancreas, such as the cystic fibrosis and pancreatitis. And we also have drug-induced diabetes, such as due to glucocorticoid use or after organ transplantation. Now let us look into the diagnosis of diabetes. So a person is said to have diabetes if the fasting plasma glucose is more than or equal to 126 milligram per deciliter, or the 2-hour the postprandial glucose is more than 200 milligram per deciliter during the oral glucose tolerance test. So the OGTT is done with an equivalent of 75 gram anhydrous glucose dissolved in water. And if the HbA1c is more than or equal to 6.5%, so this test is a very sensitive test. It should be performed in a laboratory using a method that is NGSP certified and standardized to the DCCT assay, or in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis with a random plasma glucose of more than or equal to 200 milligram per deciliter. So in the absence of unequivocal hyperglycemia, diagnosis requires 2 abnormal test results from the same sample or from 2 separate test samples. So what are the criteria for pre-diabetes? So if a person is having a fasting between 100 and 125 milligram per deciliter, he is said to be in the impaired fasting glucose range. And if the 2-hour PG is between 140 and 199 milligram per deciliter during a 75 gram OGTT, the oral glucose tolerance test, he is said to have pre-diabetes. And if the A1C is between 5.7 and 6.4, that is also confirmatory of pre-diabetes. So these are the general recommendations, the glycemic recommendations for non-pregnant adults with diabetes. So an A1C of less than 7% is what is mandated, and a preprandial capillary plasma glucose of 80 and 130, and a peak postprandial capillary plasma glucose of less than 180 milligram per deciliter. So a postprandial glucose measurement should be made 1 to 2 hours after the beginning of the meal. So ideally, we can measure it using the SMBG technique, and it can be made at 1.5 to 2 hours post meals. So we have heard about the general recommendations for non-pregnant adults in type 2 diabetes. However, the American Diabetes Association emphasizes on customized decision-making, individualized to the patient's individual needs and preferences. So the glycemic targets must be individualized in the context of shared decision-making between the patient and the caregiver. So more aggressive targets may be recommended only if they can be achieved safely and if the life expectancy is sufficient to reap the benefits of stringent targets. So this figure shows the various factors which can be taken into consideration while you make a decision for your patient. This figure is not designed to be applied rigidly. It can be used as a broad construct to guide clinical decision making. So now, so let us see how has the management of diabetes changed recently. So traditionally, it has been the management of sugars alone with the use of anti-diabetic medications. However, post the controversy of the rosiglitazone, you might remember the rosiglitazone controversy. And so after the rosiglitazone controversy, the FDA came up with a mandate that all the anti-diabetic medications except insulin should pass through the CVOT outcome trials. So post this event, the management of diabetes has transitioned from the glucocentric approach to a holistic cardiorenal metabolic approach. So it is just not the measurement of sugars alone, it is the treatment of the cardio metabolic factors as well. So based on these principles, regardless of the HbA1c level or the presence of other glucose lowering agents, all individuals with diabetes and established a subclinical cardiovascular disease should be prescribed an agent with proven cardiovascular benefit, such as those from the SGLT2 inhibitor class or the GLP-1 RA class. So this is the recent mandate that has happened. So we all know that the treatment, as Dr. Kohli ma'am was rightly mentioning, it is not just the treatment of sugars alone. We also need to come up with lifestyle modifications. We also need to have medications. Your medical nutrition therapy should also go hand in hand along with your pharmacological treatment. So limit sitting, break up your prolonged sitting every 30 minutes with short regular bouts of slow walking. And you also need to have physical activity, encourage physical activity, which should be more than or equal to 150 minutes per week of moderate intensity physical activity, or more than or equal to 75 minutes per week of vigorous intensity physical activity spread over more than or equal to 3 days a week. And you shouldn't be not doing exercise you shouldn't break your exercise in not more than 2 consecutive days. So supplement with 2 or 3 resistance, flexibility or balance sessions as well. So yoga can be helpful. Your resistance exercises can also be helpful. And sleep is also of prime importance. You need to have consistent, uninterrupted sleep, even on weekends. And it shouldn't be more than 8 hours and less than 6 hours, because this has been found to negatively impact your HbA1c levels. And the quality of your sleep is also of utmost importance, because irregular sleep has been attributed to associated with poorer glycemic controls, and it is likely influenced by the increased prevalence of insomnia, obstructive sleep apnea, etc. And the chronotype, whether you are a late chronotype or an early chronotype, there is a morning chronotype, it also depends, it also has a major role to play in the management of your diabetes. So go to bed early and get up early. So that should be your mantra. So now let us look into the therapies that are available. As we all know, the metformin is the first line of treatment for type 2 diabetes because of its high efficacy in lowering HbA1c and minimal hypoglycemia risk. And it has also got a potential for some modest weight loss. And of course, the lower cost is also a favorable factor. And we also have sulfonylureas. So this is not really the first line of treatment, but then it has got high glucose lowering efficacy. It is inexpensive, and a heterogeneous group of sulfonylureas with lower risk of hypoglycemia can be selected when you're considering sulfonylurea to be given to a patient. And we also have the thiazolidinediones, which has high glucose lowering efficacy, durability of glycemic effect, and it has got some beneficial effects in non-alcoholic fatty liver disease. And the major side effects of these are weight gain and fluid retention. And you can also combine these with the newer generation of medications. Now, we also have the DP4 inhibitors such as the sitagliptin, vildagliptin, etc. And these have intermediate glucose lowering efficacy. They have neutral effects on weight, and they are generally well tolerated with minimal risk of hypoglycemia. And the cardiovascular safety, if not the superiority, is also demonstrated. So these are the blockbuster drugs, the SGLT2 inhibitors and the GLP-1 RAs. So they reduce the renal tubular glucose absorption, and they have intermediate to high glucose lowering efficacy, lower at the lower EGFR, and they have inherent lower risk of hypoglycemia, and they also produce weight loss. The most important thing about this class of drugs, the SGLT2 inhibitors, is that they have demonstrated protective effects in different populations for their cardio-renal benefits. They reduce the major adverse cardiovascular events, that is the MACE. They also reduce the overall cardiovascular, the CV death. There is reduction in the risk of hospitalization for heart failure, and they also demonstrate reduction in the risk of kidney outcomes. So they have increased confidence surrounding the safety issues. So we also have the GLP-1 receptor agonists, which augment the glucose-dependent insulin secretion and glucagon separation. They decelerate gastric emptying. They curb the post-meal glycemic increments. They reduce the appetite, the calorie intake, and also body weight. They have high to very high glucose lowering efficacy, low inherent risk of hypoglycemia, and intermediate to high weight loss. So these are the medications. The different formulations of these medications are used for weight loss medications, even in patients without diabetes, to treat obesity. So they are cardioprotective with evidence of reduction in the major adverse cardiovascular events, the MACE, the CV death, fatal or non-fatal MI, fatal or non-fatal stroke, all-cause mortality, composite kidney outcomes driven by macroalbuminuria. So this is said to be a miraculous class of drug with so many benefits in addition to glucose lowering effect. So we have some more additions to the armamentarium of anti-diabetic medications. So we have the first oral GLP-1 RA. As you know, all the GLP-1 RAs have been injectables. We have the exenatide as the first in class, and then we have the liraglutide, then we have the semaglutide, and now the oral semaglutide has also hit the market. The brand name is Rybelsus. So we also have higher doses of the GLP-1 RAs, the dulaglutide, the semaglutide, with incremental benefits in glucose weight efficacy. So we have yet another class of drug that is called the glucose-dependent insulinotropic polypeptide, the GIP receptor and GLP-1 receptor agonist together, and the brand name is tirzepatide. The molecular name is tirzepatide. It enhances the first and second phase of insulin secretion. It reduces the glucagon levels, both in a glucose-dependent manner, and they have very high glycemic efficacy, low inherent risk of hypoglycemia, and high propensity for weight loss. And the initial results of the cardiovascular and renal outcome trials are out, and they are showing some excellent results, and they are said to be a promising class of drug to be in the market very soon. So we have another class of drug which is soon going to be launched in India, which is the imiglamin. So the mechanism of action involves dual effects such as the amplification of the glucose-stimulated insulin secretion and preservation of the beta cell mass. It enhances insulin secretion, including the potential for inhibition of hepatic glucose output, and they also involve correction of the mitochondrial dysfunction as well at a cellular level. And we also have proven the 100 years of insulin, the 100 years story of insulin, which has got an advantage of lowering glucose in dose-dependent manner, able to address any level of hypoglycemia. It has got very high to very high glycemic efficacy, and the newer analog insulins have relatively lower risk of hypoglycemia, weight gain, etc., and they have neutral cardiorenal profile. And the efficacy and safety is largely depend on how your patient is educated and how much are they going to use it. So this is the broad classification of drugs, the newer drugs that are available in the market for the treatment of diabetes. And what about the guidelines that tells you how to use these medications? The first line, of course, is metformin. And the first line depends on the comorbidities, the patient-centered treatment factors, and the management needs, and generally includes metformin along with lifestyle modifications. And in people with established CVD, as I told you before, a GLP-1 RA with proven benefit should be used to reduce the major adverse cardiovascular events, or an SGLT2 inhibitor with proven benefit should be used to reduce the MACE and heart failure and improve kidney outcomes. So in people without established cardiovascular disease, with multiple cardiovascular risk factors such as age of more than or equal to 55, obesity, hypertension, smoking, dyslipidemia, or albuminuria, a GLP-1 RA, again, with proven benefit could be used to reduce the MACE, or an SGLT2 with proven benefit could be used to reduce the MACE and heart failure and improve the kidney outcomes. So early combination can also be considered in patients who are going for a treatment failure. And the early introduction of insulin should also be considered if there is an evidence of an ongoing catabolism. So if your patient is having a great deal of weight loss, or if he's having symptoms of hyperglycemia, or when A1C level is more than 10%, or the blood glucose is more than 300, you can start the patient right away on insulin along with your metformin. So that is allowed. You need not wait until the last 2 to 3 years to initiate insulin. So initiating insulin early in the process of in the management of diabetes has also got some additional benefits. You will require very small amount of dose. If you are introducing insulin very early in the management of diabetes, you will not go for any complications. So all these are proven. They have proven benefits, and all these have been published. So, so this is the broad picture published by the American Diabetes Association and the European Association for the Study of Diabetes. You have metformin as a first line along with your lifestyle modifications. And now you need to look at whether the patient is having any comorbidities. So if the patient is not having any comorbidities, you can look at other factors such as is a patient having a propensity for hypoglycemia. So if your focus is to minimize hypoglycemia, you can go for DPP-4 inhibitors, GLP-1 RAs, or SGLT2 inhibitors, or your thiazolidine. And if the A1C is above target still, you can incorporate one or two other agents. And if your focus is to minimize weight gain or promote weight loss, then you can go for GLP-1 RAs or the SGLT2 inhibitors, because both will give you some amount of weight reduction. And if cost is your consideration, your resources, you're practicing in a resource limited setting, then you can go for sulfonylureas or T-series, but they are not really indicated as a first line or second line of treatment. But if your patient is already having an ASCVD risk, or he already had a cardiovascular event or a kidney disease, then you need to give your priority to your GLP-1 RAs or your SGLT2 inhibitors, because all these drugs, this category of drugs, do have proven benefits in terms of cardiovascular safety and renal safety. So the treatment of diabetes is not just the treatment of sugars alone. You also need to control your blood pressure and your cholesterol levels for a successful management of your diabetes. So blood pressure should be measured at every routine clinical visit. And when possible, patients found to have elevated blood pressure, that is a value of 140 over 90, should have blood pressure, they should be measuring it multiple times on a separate day to diagnose hypertension. But if a patient with blood pressure of more than 180 over 110 millimeter of mm of Hg and cardiovascular disease, could be diagnosed with hypertension at a single visit. So all the hypertensive patients with diabetes should monitor the blood pressures at home. For individuals with diabetes and hypertension at lower risk of cardiovascular disease, then treat to a blood pressure target of less than 140 over 90. And what about the statins? For patients with diabetes aged 40 to 75 years without atherosclerotic cardiovascular disease, use moderate intensity statin therapy in addition to your lifestyle. For patients with diabetes aged 20 to 39 with additional atherosclerotic cardiovascular disease risk factors, it is reasonable. It is quite reasonable to initiate statin therapy in addition to the lifestyle therapy. And in patients with diabetes at high risk, especially those with multiple ASCVD risk factors or age 50 to 70 years, it is reasonable to use a high intensity statin therapy. And in adults with diabetes and having 10-year ASCVD risk of more than 20%, it may be reasonable to add ezetimibe along with the statin therapy to reduce the LDL. So what do you mean by high intensity statin therapy and moderate intensity? So atorvastatin of 40 to 80 and rosuvastatin of 20 to 40 falls into the category of high intensity statin therapy, and atorvastatin 10 to 20, rosuvastatin 5 to 10, all these come under moderate intensity statin therapy. So I have discussed about almost all the pharmacological agents, the newer pharmacological agents which are available in the market. So what about the technologies that are widely used in diabetes? So ever since the emergence of Corona, then we are using telemedicine up to a great extent, and we are tapping the resources that are available in terms of technology for the management of diabetes. So continuous glucose monitoring is one among them. So we are aware of the fact that we started using the urine sugar to monitor our glucose, and then we started doing the SMPGs, self-monitoring of blood glucose using the glucometer and the connected glucose meters. And now we are also depending on HbA1c as a 3-month average of the blood sugars. And now we have a new target, that is the time in range, which is actually which you actually receive from the continuous glucose monitoring data. So what is continuous glucose monitoring? We have a different classification for continuous glucose monitoring. We have the real-time CGM, which measures the glucose levels continuously and provide the users automatic alarms and alerts at specific glucose intervals when the blood sugar is fluctuating, when the blood sugar is going high, low, etc. And we also have the intermittently scanned CGM, that is the IS CGM, where you need to place a reader, a smartphone-like thing over your sensor. That is a sensor which is measuring your glucose levels continuously so as to get the reading. So that is intermittently scanned CGM or the flash glucose monitoring. We also have the blinded or the professional CGM, which measures glucose levels that are not displayed to the patient in real time. It is activated at the doctor's office, and the patient can go home. He can come back after 10 to 14 days, and then the doctor and the patient sits together and analyzes the glycemic patterns and trends, and then they are involved in shared decision making. So these are the various classification of CGM. So we started with the CGMS Gold in 1999, and then came the iPro 2, which is a blinded CGM. The patient can't see the values in real time. Then came the this one, the third one, the Libre Pro, which is also a blinded CGM. So the patient will have to come back to the doctor's office to see the glucose trends and values after 14 days. And then came the real-time glucose monitoring, the continuous glucose monitoring, which is called the Guardian Connect. Here, the patient can see his or her values in real time in the mobile phone. He can use an app and he can see the values in real time. He can enter all the essential information, such as the medications that the patient is taking, the diet, the exercise, all those relevant details, all can be fed into the phone, and you get the values in real time, and you also get the glucose trends also. And you also get the alarms and alerts if the glucose is going high or low. And you recently have the Freestyle Libre Pro, which was launched in 2020, which is also a flash glucose monitoring, but you have a reader with you. It is with the patient. The patient can see it in real time if they are scanning the reader over the sensor. The black one is the reader and the white one is the sensor. So these are some examples of the Guardian Connect real-time CGM, where you can see the values, the trends, etc., as you can see in the graphs. And you also have the Freestyle Libre Pro, the Freestyle Libre, where you have the black reader and you have the white sensor, and you can see the arrows which shows that the glucose is rising quickly, falling quickly. Whether if there is a stable arrow, it shows that the glucose is changing slowly, or rather it is stable. So these are some of the CGMs that are available in the Indian market as of now. So we all know that A1C fails to identify the magnitude and frequency. You just get the average. You get a percentage which gives you the average of the last 3 months blood glucose values. However, the continuous glucose monitoring gives a video of the blood sugar patterns. That is, it helps to identify the magnitude and the frequency of the intraday and the interday glucose variations. We all know that the glycemic variability has been attributed to complications in diabetes. So to minimize the complications, we need to know what is happening in between a particular period. So we have time in range as the new target, which was recommended by the consensus group at the HTTD, ADA, and the ESD consensus meetings that happened in 2019. So these are some of the summary of the TIR targets for different diabetes population. As you can see here, for type 1 and type 2 diabetes, the target range is 70 to 180 milligram per deciliter. And a patient, a type 1 diabetes or a type 2 diabetes patient should spend more than 70% of his time in range between 70 and 180 to be said to have a good glycemic control. And we should also make sure that the patient is not having a low sugar, that is a time below range shouldn't be more than 4%. It should be less than 4%, and it should not be more than 1% if the patient is having a low glucose of 54 milligram per deciliter. So this is level 1 hypoglycemia. Any value below 70 is level 1 hypoglycemia, and any value below 54 is level 2 hypoglycemia, which is serious hypoglycemia and is dangerous. So the patient shouldn't be spending more than 1% time in severe hypoglycemia, and this also decides the treatment success of the patient. And for older adults and those with multiple comorbidities, the time in target can be kept at more than 50. They shouldn't meet a target of more than 70. It can be kept at more than 50. And in pregnancy and in pregnant ladies where they have type 1 diabetes, the target is 63 to 140 milligram. They have stringent targets in pregnancy, and the time in range should be more than 70%. And as you can see, the time below target is 63 and 54, in contrast to the type 1 and type 2 diabetes general population, where the target for time below range is 70 and 54 milligram per deciliter. We don't have much evidence for pregnancy and gestational and type 2 diabetes, so they're not providing with a time in range for this category of people. And my presentation wouldn't be complete without mentioning about automated insulin delivery systems, or the artificial pancreas, or the insulin pumps, as we all know. So what is an automated insulin delivery system? So this system automatically adjusts the insulin delivery to help control your blood glucose levels. We have the syringe, we have the pen, and we also have the insulin pump. So insulin pump is a more sophisticated device, and the newer terms for insulin pump is artificial pancreas or automated insulin delivery system. So what does it include? It includes a continuous subcutaneous insulin infusion via an insulin pump, that is the blue device over here. We have a CGM system. The Dexcom G6 is a real-time CGM, and we have a rapid-acting insulin analog such as a Fiasp or Novorapid, which goes into the insulin pump. And we also have an algorithm that automates the pump's delivery of the insulin based on the CGM data, which is available on your smartphone. So this makes an automated insulin delivery system, or the artificial pancreas. So the new name for an artificial pancreas is automated insulin delivery system, or AID. So the best device that we have in the Indian market as of now is the Minimed 780G from Medtronic, which automatically adjusts insulin delivery and corrects the highs and lows every 5 minutes without the patient going for a very low sugar. So the bolus, that is the insulin that is delivered soon after or just before your main meal, is called the bolus, and the bolus is delivered automatically up to every 5 minutes if algorithm determines if it is needed. So this is almost like completely closing the loop, and it is almost like fully automatic insulin pump. And the newer research is in the direction of non-invasive blood glucose meters and non-invasive CGMs. We have the world's first to use patented high-tech non-invasive blood glucose meter here. It is called the e-Touches. It can be used in normal pre-diabetes and type 2 diabetes patients. It is exorbitantly expensive. It is almost like 28 to 30,000 rupees. And we also have an Indian innovation in the market, which is called the AVA from Blue Semi. It has got innovative patented technology, leveraging the sensor fusion, the smart Internet of Things, and accurate AI algorithms. So these are the new research that is happening in the field of diabetes. We are looking for some non-invasive glucose meters as well as the non-invasive CGMs. So my bottom line to conclude, let me say that team-based care is required for integrated care of diabetes. You, me, along with the doctors, the dietitians, psychologists, etc., should come together for successful diabetes management. And also, we need to go hand in hand with other medical specialties such as the primary care, the endocrinology, the ophthalmology, nephrology, etc. So let's work towards that and let's make it work. Thank you so much for your patient hearing.
Thank you. Thank you, Ms. Gopika Krishnan. And here I would like to welcome Dr. Veni, the ardent academician, researcher, and a dedicated assistant professor. Her academics include first rank holder in MA Psychology from Kerala University, MPhil in Psychology from Kerala University, qualified her NET National Eligibility Test and state eligibility test both from Kerala and Karnataka, who at present working as assistant professor of psychology in Jyoti Nivas College, Autonomous in Bangalore. Her areas of interest include clinical psychology, positive psychology, social psychology, counseling psychology, and psychopathology. She published papers on both national and international journals, had research work on various aspects of learning disabled children in the schools of Kerala, and presented several papers on the subject of her expertise. I would like to request you to take over the section, Dr. Wayne. Thank you.
Thank you, Mrs. Ramya Gayatri. Thank you, Rashmi Chandran. Let me just share the screen and I'll start. Hope I am audible. Am I audible?
Yes, ma'am. Yes, ma'am, you're audible.
Okay. Good afternoon, everybody. Thank you. I would like to thank IPGA Women's Forum Kerala for this wonderful opportunity to present, along with such eminent resource people, especially my presentation will be a little different from what you have heard till now. I mean, it was pretty technical and then mostly focusing on the physical aspects of diabetes. So my motive here, being a psychologist, is to focus on diabetes and mental health. Why we are linking diabetes and mental health? Because the reason being, it's been observed through various research that people with diabetes actually go through a lot of mood swings, and then they actually undergo a lot of stress, and then they have difficulty in adjusting with the different changes that may occur because of diabetes. So it has been noted that diabetes can lead to major behavioral changes too. So they may find it difficult to communicate with other people, socialize with other people, and also it is something that they have to deal with throughout their life. It is not something that, like some of you were mentioning, where it's not about cure. So maybe you have to adjust, and then you have to modify or alter your lifestyle according to the need of the illness. So that's why it's very important that we need to focus on the mental health along with the physical health. So the session by Mrs. Gopika Krishnan was very effective and very informative. And she has covered almost all the technical aspect and then the kind of management and the treatment available in terms of the physical illness. So my focus with regard to this session is to focus on some of the psychosocial interventions or management strategies that can be applied along with the medical care. So I'll be focused initially to start with what are the issues that these people face, people who have been diagnosed with diabetes face mentally along with the physical illness. So the major psychological impact, as you can see, some of it I've noted down here. Definitely it leads to a major lifestyle change. So it may lead to major distress So it's not simply stress. We have to, there are positive and negative stress, obviously. So here it is an extreme negative stress that these people go through. And then because it's sudden, when immediately after diagnosis, they will experience multiple emotions. It can be like how to manage, how to track their blood sugar levels, or then dosing of insulin, or planning their meals. And they have to have they have to stay active, and then they have to have a proper schedule in terms of their physical activity. So how do they manage it, and then how do they follow it throughout their life is what is may cause a major distress or negative stress in their life. So along with that, when they get to know initially that they're undergoing some sort of an illness which may require treatment throughout their life, definitely they may indulge in, it has been seen through research that they may indulge in maladaptive coping strategy. So there can be adaptive way of dealing with the situation or maladaptive way of dealing with situation. So most of the research has shown that initially when they have been diagnosed with diabetes, they tend to use denial or any kinds of defense mechanisms as a way to deal with the disease, rather than focusing on the positives, and then how to focus on the how to accept the situation. So that's why maladaptive coping strategy is one of the psychological impact that has been seen among them. And another major impact that has been noticed is they might have extreme negative thoughts or negative outlook towards life and future. So they have a pessimistic attitude towards the future, where they will feel that they may not be able to deal with it, and then they feel that they'll be a failure. They will end up in trouble. They will have a lot of issues in the future. So whenever we talk about pessimism and optimism, it's about the future events. It's not about the current situation. So they are, they're giving up on most of the, though it can be physically, they might be taking medications, they might be going through the treatment, but still, because of their pessimistic attitude, that may reflect in their health directly. So it has been also been found through research that they are high in risk of developing depression, anxiety, and eating disorders, mostly, along with the other psychological illness. Definitely depression because of the hopelessness, helplessness, and then they feel that there is no way that I can move ahead, so the better that I give up. So that kind of attitude can result in depression and anxiety, where they are extremely apprehended about their future. They don't know what the future will bring, and then they don't know how they will deal with it, how they will manage these life-changing lifestyle changes throughout their lives. So that they're always apprehended. So definitely that can lead to anxiety disorders too, and also eating disorders such as bulimia. They have binge eating disorder or anorexia, where they may not have any food. They will not intake. They will not have consume any nutritional food also. So instead of skipping what is necessary and what is not, so they will not have any differentiation in terms of what to eat, what not to eat. Sometimes they may indulge in extreme diet, which may reflect in their their physical activity also. So it's not that you shouldn't eat anything, it's about what to eat, what not to eat. So definitely these people may tend to develop eating disorders such as binge eating, bulimia, and especially anorexia, where they may indulge in eating less food, or they may starve to a point where they'll be bedridden and they need medical help throughout. So that's why that's one of the major impact of diabetes. And then because of this extreme stressors that they are going on, and then because of this denial, and then they go through multiple emotion also. Either they will be angry, they'll be sad, they'll be scared what to do. So it depends on people to people. We can't say that every single person with diabetes go through the same symptoms, but they do go through multiple emotions, various emotions where they have no control over it. So they may feel extreme anger or extreme sadness, and then why me? They may question themselves that why me? Why is it happening to me? So definitely they are scared what the future will bring. How will they manage it? How will they actually go through the stressors associated with the illness along with their day-to-day issues? So this, in a psychological term known as diabetes burnout, because of the major changes that they are going through, they are completely exhausted by the stressors along with the physical issue. Because of the mental health issue that they develop, it may lead to diabetes burnout also. So these are those are some of the identified psychological impact that has been seen among patients with diabetes. Definitely there are other issues also they may face, depends on people to people, because people are unique, and then they may develop some other psychological issues too. So I'll be focusing on in this slide about what are the remedial measures that we need to focus on, or the psychotherapies that is available and then has been used frequently in the field of diabetes. So some of the therapies I've given. Along with that, there are other positive psychology treatments that is available, along with the medical care that has been extensively spoken by the resource person. So here, the first therapy that has been used in various treatments not only limited to diabetes, it has been used widely in the field of psychology. So cognitive behavior therapy, where cognition means your thought processes, how it actually changes your behavior. So this particular treatment focuses on helping patient aware of the inaccurate or the negative thought process or the thinking that they have. So they may feel that they are inadequate. They may feel that they can't deal with it. They may feel that it may their life will be extremely like a difficult one. So there are multiple negative thoughts. Depends on people to people. Depends on the extent of their illness also. But the main aim of cognitive behavior therapy is to change their negative thoughts or the negative thinking into positive by using multiple challenging questions. And so this is a widely used techniques, widely researched one, and then widely practiced technique that has been used in dealing with disorders, and especially diabetes. Along with cognitive behavior therapy, another psychological treatment that can be used among patients with diabetes is family therapy. So as you know that whenever we talk about diabetes, families are also involved equally along with the patient. So it intend to help family to improve communication and also to resolve their conflicts. So if they have any kinds of conflict, it can be resolved using cognitive behavior therapy, family therapy, along with other treatments. So other than family therapy, there are multiple treatments available in the psychology field. So the third therapy that has been widely used was motivational interviewing. So motivational interviewing, from the name itself, as you can make out, that you are trying to, it is kind of a counseling itself. It's an effective kind of counseling which enhances the motivation of the patient through because most of the time what happens is, why motivation? Because they will have mostly mixed feelings or contradictory ideas about the illness and how to deal with the illness. So that's the reason why it is very important to have counseling where the therapist aim is to motivate the patient towards in the positive direction, obviously. So how to deal with it, how we can actually, anyway you have been diagnosed with something, and then how we can actually deal with it, how we can adjust with the lifestyle changes. Now, the fourth therapy that has been widely used in terms of diabetes, not only diabetes, even in the other behavioral issues also. So let me show some of the stages of how behavior changes from the time they have been diagnosed with diabetes. So initially you tend to believe that I don't have it. You tend to deny it. Denial is one of the way defense mechanism that has been used in almost all the disorders. Whenever they have been diagnosed with anything, illnesses, they tend to deny it, and then you tend to believe that okay, it's a mistake. It might be a mistake. I don't have the disease, so that's the first stage where you are not ready to accept the fact that you have a disorder. Now, the second stage where I am no more happy, I am worried. So you are undergoing a lot of stresses here, and then I'm having diabetes. So you're accepting the fact, you are trying to accept, but you're undergoing a lot of mental health issues here, extreme distress, extreme anxiety. So you feel that I want to live. I want to save myself. So you are thinking, how do I prevent it? So in the second stage and the third stage, it is a preparation stage where I am ready to change. So you are trying to make yourself aware of all the pros and cons and what are the things that I need to do to change and then follow a particular protocol. And behavioral modification talks about how the next stages, that is the action and maintenance stage. Till the first three stages, you yourself will go through in most of the situation. You might not need a therapist. If you're still struggling, most of the patient, not necessarily every single person need a psychotherapy in this stage, but some of them, they themselves will find adaptive coping mechanisms, and then they will find how to deal with the diabetes, and then they will try to follow the adequate way of functioning. But if the patient is not able to deal with their lifestyle changes, and they are not able to go further with regard to this, so you're just stuck there, then definitely you need to seek help, and you need to get help. And then being a psychologist, I can say that psychologist can, or a psychotherapist or a counselor can help in modifying their behavior through constant monitoring. So here, in terms of dietary changes, in terms of physical activity, regular medications, regular therapy or counseling, or peer help. It's not necessarily always you need to meet a psychologist. Maybe in the initial stages you can meet the psychologist, and later on you can have peer interactions, and then definitely group therapy. Next thing I will be talking about the group therapy that can also help in terms of keeping up with the challenges that you will be facing in your future. And definitely maintenance is the key in any behavioral modification. If you're not able to, maybe definitely you have reached the point, you started doing whatever is required to do, but whether you are able to continue functioning in the right direction or in the positive direction, that makes a lot of difference in life, especially the patient with diabetes. So here, you yourself can actually reinforce yourself using both positive reinforcement and negative reinforcement. So for this stage also, if the patient is not able to help themselves, so definitely they can seek help. And as being a psychologist in the field of psychology, clinical psychology, or in the counseling psychology, they can actually help them follow this or maintain what exactly that they have decided to do. So those are the behavioral modification sections. So everything can be monitored, including whether they are following the protocol, whether they can even keep a journal of writing it down, what are the things that need to be followed in terms of medication, in terms of their physical activity, in terms of diet modification. So whether they are following it or not, keep a journal. Self-monitoring is very important. Along with that, if they are not able to function adequately, if they are not able to function adequately in a day-to-day basis, definitely they should seek help from a psychologist. And like I was talking about group therapy sessions, So along with the behavioral modification and other kinds of therapies, it's very important that there should be some sort of a social support, psychosocial support, or the peer support groups can help each other because they all are going through the similar experiences, not exactly the same experiences, but similar experiences. So they can share their way, how they are actually following these treatment regimes, and how they are actually following the the lifestyle changes. So how they're able to maintain it. So definitely they can have discussions with each other, and they can help each other deal with the issues more effectively when you're doing it alone. So when you know that there are multiple people who are actually going through the similar issues, rather than it's not always me alone. So that's something that actually causes a lot of mental health issues, where you feel that why me? So here it's very important. You should know that there are so many people who are going through. I think the numbers are many. In the previous sessions, I've heard that many numbers they are spoken already. So it is so you know that many people are going through similar situations, and then if you can put them in the group and with the help of a therapist, and bring that peer group interaction, and then they may feel motivated. They can motivate each other, and they can help each other change their lifestyle. So group therapy sessions can also be conducted with the presence of one or multiple psychotherapists. So it's not limited to one therapist. Sometimes you need to have multiple psychotherapists. Along with that, the people who are actually suffering. So other than these 5 therapies, the recent therapies, recently it has been, they have been talking about mindfulness. So mindfulness is one of the positive psychology, practice. We can't say it's a therapy, we can say it's a practice, where you are trying to make them understand the present. So it's the focus is on present rather than the future. So when you think about future, you will always, you are worried, you're apprehended about what's going to happen. How will I maintain? So you're always worried, and then you have a lot of, you have your job, you have your day-to-day rituals, you have your family to take care of, multiple things that you go through. So all those things bothers you all the time, so may result in a lot of mental health issues. So mindfulness teaches you to focus on the present moment rather than getting distracted by the multiple stressors of life. Then one of the major important aspect other than the therapy is emotion regulation. Like I was saying in the initial, when I started the session, they undergo a lot of emotions, and they may find it difficult to understand their emotions too. So that's why the recent field where we talk about emotional intelligence. So it's very important that you understand your emotion, and then it's more than understanding, it's very important that you learn to manage and control your emotion. So because you are so frustrated, and then you're angry or you're sad, you can end up showing it in your work, you can show it in your houses, or maybe the people around you will be affected. Along with you, you will be affected. At the same time, the people around you will also get affected by the emotion. When you are not able to control your emotions. So that's why emotional regulation strategies are very important. If you're not able to control your emotion, or if you have no control over your anger or sadness or anything, it's very important that you seek help. And it's very important to have adequate interpersonal relationships to deal with the stressors of the diabetes. So it's not limited to one person. So like in the group therapy, we are talking about people with similar issues are coming together and discussing, and then they are finding out the solution to it. In here, we are talking about how important it is to have friends around you, how important it is to have interpersonal relationship, adequate relationship, positive relationship. So very important to have your family around you, and then your it can be family or friends that whom you are dependent on. So it's if you are not able to control your emotions, definitely that will reflect in your interpersonal relationship also. So that's why it's all go hand in hand. So once you have control, if you are extremely angry, so you will show it to your friends and family, so they may not be able to support you adequately. So that's the reason why we need to regulate our emotion, at the same time focus on forming positive relationship or effective interpersonal relationship. The management, I think this has been spoken multiple times during the sessions, but self-management task, what are the things that they need to focus on other than the medications, and all those things have been discussed in detail, so I'm not going there. So definitely diet and exercise, regular therapy injections, depends on people to people, what exactly is their problem, self-monitoring, self-adjustment of the treatment, whenever it is required, clinic visit, and also psychotherapy, though it has not been spoken much, there is no stigma associated with it. The people are reluctant to meet a psychologist or a therapist because of the stigma associated with it. So we need to come in front, and then you need to deal with it if you actually wanted to move further adequately in a positive manner. If you need help, definitely it is very important that you need to seek therapy, adequate therapy, along with the medical care. So what are the outcomes of the therapies that I was discussing about? The most important outcome here is definitely the bringing in motivation, and then they should feel that, okay, I can deal with it, and then I can follow the rituals, I can follow the routines, and definitely bringing adaptive coping strategy instead of maladaptive or negative coping strategy. So it's always the best way of deal with situation is problem focused coping strategy, where you know that these are the issues that I am facing, so what can be done about it to change it. So even whether it's like physical illness, or whether it's like the mental health issues that you are facing, what are the adaptive or positive way of dealing with the issues. So you need to focus on the adaptive coping strategy and emotional stability, or having a higher emotional intelligence. So emotional intelligence is proved to be more important than your general intelligence, because here you are dealing with other people. So it's not limited to you. We as human beings, we always need other people. It's as we are social beings, obviously. So we need other people around us. So that's why if you're not stable enough, it will affect you at the same time, the other people around you. So that will not help you function adequately in the future. Then you should have a positive outlook or optimistic view about your future. So most of the cases, like I was saying, it starts with extreme pessimism, where they will just they'll think that there is no point in doing it, there is no point in focusing on these treatment, and then changing my lifestyle, and then going through all those exercises, and then physical activity, changing my diet, focusing on a particular kind of food that you are eating, and proper medication. So you tend to believe that it's of no use. Why would I just go through it? I'll just live my life the way I wanted to. So that shouldn't be the attitude. So that's a negative way of dealing with the situation. So here you need to have a positive outlook, that how you can bring in changes by altering it. So once you know that, okay, it is something that you can't cure it in a day or two, so how can I move forward positively? And so you should have a positive outlook or an optimistic view about your future. Then ultimate aim of ultimate outcome, definitely as a psychologist, is you should have an increased quality of life, and then life satisfaction. So if you are not happy with the way you are living, that will reflect in your day-to-day. It can be in your work, in your families, and it will affect your illness. Also, physical illness is directly related to how you feel mentally. So life satisfaction is the ultimate aim, and then overall well-being. So you should feel happy about your life. So if you're not happy, you tend to okay. I think the screen has been disabled. Okay, so I'll just continue. So should I share the screen or is it fine?
No, ma'am, you can share the screen again.
It says disabled. It says host disabled participant sharing. Yeah, so I'm not able to share it. Anyway, so I think I'm in the end of the session, so that's fine. So ultimately, we should look for the happiness or the well-being, overall well-being, where you should.
Excuse me, ma'am.
Yes,
Please try again. Can you please try again?
Yes, yes, yes. Yes, sir. Now it is possible.
Okay.
Yeah. Okay, so we need to fix the issues, and then at the end of the day, everybody has to focus on the overall well-being. So you should feel good about your life. You should have an increased quality of life, positive outlook about your future, and definitely deal with it in a positive note. So other than the therapeutic techniques that I said, so nowadays I think in psychology, there are a lot of positive psychology interventions that can be used to have a day-to-day to increase the positivity in general. So you can engage in such activity which will bring in positivity in general. So that will reflect in the way that you deal with the illness also. So I think I'll end my session here. Yeah, thank you. I'm not able to change the screen. It's stuck. Okay, so thank you. If any questions, you can, any queries, you can just ask. Thank you. Thank you all.
Thank you, Gopika madam and Veni madam. Now the session is open for queries. Participants can unmute yourself and ask the queries related to diabetes management and psychological impact. We have few questions in the chat box also.
Yeah, I already answered to those questions. I privately messaged them. So, yeah.
Okay. Madam, can you just share the views on that questions publicly?
Okay, yeah. The first question was
how to manage weight?
Is there any infection or microbes that can damage the beta cells or can lead to diabetes? So in my knowledge, there are a lot of viruses such as the enterovirus, the Coxsackie virus, rotavirus, mumps, rubella, etc., which can cause autoimmune, the type 1 diabetes. And you also know that COVID has been associated with a lot of new onset diabetes, especially type 1 diabetes when compared to type 2s. So yeah. So that is what is known to my knowledge. Yes. If any others have anything to add, they can also contribute. So another question is if the blood glucose levels are not effectively managed. So did high level of sugar for several years cause nerve damage? So yes, if the blood sugar levels are not effectively controlled, then it can lead to neuropathy. All the microvascular and later on the macrovascular complications can set in. So that is a known fact that is demonstrated in various trials as well. So if you have a stringent glycemic control, then the time by which or you can rather prevent the complications of diabetes. So yeah, yes, controlling your glucose levels is of utmost importance. And how can a type 2 diabetic patient gain weight without increasing blood sugar level? So I'm not sure about this question, but what I perceive is that if a patient is lean and he want to gain weight, but he is already having diabetes, then probably this patient need to discuss this with their diabetologist, because as I already discussed, there are a lot of medications which can cause weight loss. So if you are definitely looking for weight gain in a patient, then probably you will have to cut down on those medications and probably add some human insulins so that there is some amount of weight gain, and then without increasing their blood sugar levels. So yeah, that is what I recommend. And you can also discuss with your dietitian how to increase your food intake without negatively impacting your blood glucose.
Madam, there is one more question in the chat box right now. Why it is difficult to heal skin injuries for a diabetic patient?
It is not really difficult to heal skin injuries or food ulcers. The crux of the matter is controlling your blood sugars. So that is what I can definitely tell you, because I've been with doctors treating diabetes for the past maybe 12, 13 years. And what I have seen is that there are non-healing foot ulcers, and the single most reason for a non-healing ulcer or a skin injury is uncontrolled blood sugar. So if you're definite to control your blood sugars, then your wound is definite to heal. So that is the crux of the matter. You need to control your sugars. And in addition to controlling your sugars, you also need to take care of your blood pressure and also your cholesterol levels. So there are ABCs of diabetes. A stands for A1C, B stands for blood pressure, and C stands for cholesterol. So you need to have a control of all these three parameters to tell somebody that your diabetes is under control, rather than just control of blood sugars alone.
Madam, next question is that I was recently diagnosed with the type 2 diabetes mellitus. Do I need to see an endocrinologist?
Yes, definitely, because there are a lot of misinformation that is happening in the social media. A lot of unscientific information has been circulating over and again that diabetes is curable. But we have all learned, if we go back to our basics, we have all learned that type 2 diabetes is not actually curable. But then you can have a remission of your diabetes if you are able to reduce your body weight, if you're going back to your ideal BMI, and if you can control all those parameters which has actually contributed to your new onset type 2 diabetes, you can definitely go for a remission. But then if your HbA1c is like more than 7%, if you have other parameters which are uncontrolled, then probably you need to visit your endocrinologist or a diabetologist, seek their advice, do all the tests that are important, such as your biochemistry, your HbA1c, your OTPT levels. All these parameters should be taken into consideration, and make sure that all these values are under control. And you can go for some lifestyle modifications along with your medications. And there are a lot of medications now available which can actually help you for a remission of diabetes. For example, the GLP-1 RAs, they have proven efficacy in terms of remission. We have a lot of patients, and we have already published the data on that, where GLP-1 RAs along with your metformin can cause the new onset type 2 diabetes to go for a remission. For that matter, insulin can also cause a remission of diabetes if you're starting insulin very early, afresh, without introducing sulfonylureas into your management. If you're introducing insulin into your treatment along with metformin when you're newly diagnosed with diabetes, and if you're following an intensive insulin therapy with structured SMBG, you can actually go for a remission of diabetes. But make sure that you're not going back to your unhealthy lifestyles, you are exercising regularly, you are planning your nutrition accordingly. You can of course go for a remission, but there is no cure of diabetes, because diabetes, as we all know, has got almost like 13 pathogenic factors, or there's a lot of factors which are involved in the pathogenesis of type 2 diabetes. So you can at least revert some of them, but make sure that you're following a healthy lifestyle post that.
Madam, another question is that whether we can stop insulin after starting for a few days.
Yeah, exactly. Because there is an old myth that once you start on insulin, then there is no going back. So that is something, a very traditional approach. So if you ask me, I have seen a lot of patients where we start a new onset diabetes patient on insulin when their HbA1c is more than say 10% or so. And if you're continuing insulin, an intensive insulin therapy for another say 6 to 8 months, we can definitely achieve an A1C which is less than 7%, and or for that matter go for a remission of diabetes with an HbA1c of somewhere like 5.5 or 5.4, which denotes that the patient is not having diabetes. And you can for sure stop insulin and put that patient on diet and lifestyle modifications, and you can of course stop insulin. But if you are starting your insulin at a later stage in the diagnosis of diabetes, if you are starting insulin after the onset of complications, then there is no going back. You will have to have insulin throughout your life. So it depends on what stage you are actually initiating the patient on insulin.
For next question, I think Veni madam also can join. That is, the question is there any relation between menstrual cycle, menopause, and diabetes? Issues related to menstrual cycle, menopause, and diabetes.
And Veni, can you hear you? Was a question to me?
I mean, the scientific things I can't talk. I think ma'am has to talk. If it is anything related to psychology, I can.
Is there any relation between menopause and psychological issues with respect to diabetes? Is the patient is diabetic,
okay.
and
okay, psychological issues, definitely yes. I mean, during menopause itself, they go through a lot of issues. I mean, other than the diabetes, even if you don't have diabetes, also they go through a lot of psychological issues. So they will, because it's an alteration, it's a modification in their lifestyle. You don't have to have an illness to face that changes. So along with that, if you have been diagnosed with diabetes, definitely it is, I mean, they go through multiple stressors rather than just limited to the issues related to menopause. Yes, they may go through multiple issues.
Yes, in our experience, we have seen a lot of women going through this conflicting periods when menopause approaches, and there is also there is a chance for an increase in the blood sugar levels because there is more of insulin resistance, and there is also a lot of emotional issues happening when a woman approaches menopause. So there are a lot of issues happening when if the particular patient is having diabetes along with and when menopause is approaching. So there is a lot of hormonal changes happening, and if we are not providing a patient with hormone replacement therapies, which are usually given by gynecologists, they can of course have glycemic variability, uncontrolled glucose levels, etc. But if there is a proper planning, if a gynecologist is also part of the diabetes care team, then these kind of issues can be resolved up to a certain extent. Of course, a counselor, a psychologist should definitely help. A lot of counseling can help women during those periods. Yes.
And there is a question in the chat box from Swati. What about developing tolerance to anti-diabetic drugs?
So, so initially, I'm not sure about the question, but what I believe is that in our academic days, we used to be taught that there is a failure of sulfonylureas. So it is, but later, as the research evolved, we have learned that it is not the sulfonylureas which fail. It is actually the beta cells that fail. Because when we are diagnosed with diabetes, almost like 50 to 60% of beta cells have already been lost. And that is when we are diagnosed with diabetes. So if we are put on medications, which are actually the secretagogues, such as the sulfonylureas, when we are putting these patients on secretagogues and such type of medications which actually squeeze the beta cells further, then there is always a chance that the patients can go for uncontrolled blood sugar. So it is not actually the medications which fail, it is actually the beta cells which fail. So if we are introducing medications which do not actually directly target the beta cells, such as the GLP-1RAs, the SGLT2 inhibitors, the DPP4 inhibitors, etc., then you won't actually develop tolerance to anti-diabetic medications. It is not actually tolerance to medications, it is your beta cells which actually fails. So what about keto diet in the management of diabetic? So I'm not actually very good at answering diet questions, but then we do not promote keto diets because, as you know, and as the evidence tells you, keto diet has got a lot of side effects in the long term. So in the short term, it is actually proven to be beneficial, but it is not so in the long term. So we don't recommend keto diet for any of our diabetes patients. So can diabetes pass from father to son? So if it is type 1 diabetes, it need not pass, but there is a certain amount of percentage chance that type 1 diabetes can pass from father to son. But in case of type 2 diabetes, yes, type 2 diabetes is genetic. But then if you're following a healthy lifestyle, if you're preventing the pathogenesis which can lead to type 2 diabetes, such as obesity. If you're following a healthy lifestyle, if you're exercising regularly, if you're modifying your food and your other behaviors accordingly, like if you're having a very good sleep, if you're physically active, then probably you can prevent type 2 diabetes from happening up to a certain extent. Yes, many of our patients have proved this to us. Yes, you can. Thus, taking metformin in low dose in conditions like PCOS predisposed to diabetes mellitus. That is from my colleague, from my classmate Meenu. And no, Meenu actually low dose, does taking metformin in low dose in conditions like PCOS. Not actually, because we use metformin as a treatment, as a first line of treatment for diabetes mellitus, and it is shown to have some additional benefits in cancer prevention, etc. So taking low dose of metformin in PCOS doesn't predispose you to diabetes mellitus. It is actually the insulin resistance that is there in PCOS which is actually predisposing you to diabetes. It is not metformin.
Madam, next question is related to the use of glucometer and insulin pen. That is, how often it should be replaced and how it should be stored, etc.
So the average life span of a glucometer is, as per the textbooks, it is 4 to 5 years. But in my knowledge, it works even more. But make sure that you use the glucose meter properly, you store it properly. Make sure you don't have the blood spots, the residual blood being there in the glucose meter. So all those can attract ants and things. So this can actually negatively affect the lifespan of glucose meter. Solidly, I can say that you can use a particular glucose meter for up to 4 to 5 years, definitely. But make sure that you use it, you store it properly. So unfortunately, my friend died because of type 1 diabetes, because the medical professionals didn't know he was during hospitalization. He also didn't inform that he was unconscious, whether it is good to check. Actually, to be precise on this question, my daughter is having type 1 diabetes. She was diagnosed with type 1 diabetes during the COVID period. So it is so unfortunate. I being working in this in diabetes field for more than 13 years, and my daughter having type 1 diabetes is it's a paradox. But then I've learned a lot of things since she was diagnosed with type 1 diabetes. I've been working as a diabetes educator along with doing research in diabetes. And what I have understood is that if you have type 1 diabetes, if your child is type 1 diabetic, you make sure that you inform all your kith and kin. They must inform it in the school. They must inform it to your neighbors, whoever is there, your parents, your grandparents. All the kith and kin must be informed that the child is having type 1 diabetes, because we have many cases where they don't disclose. There is always a stigma associated with type 1 diabetes, and they don't disclose it to their near ones, their relatives, etc. And terrible things have happened in the past, where the child goes for a severe hypoglycemia. They feel unconscious during the assemblies. People don't know what is happening. They run. So if a severe hypoglycemia is not managed as an emergency, then death can occur. So there is the best thing to do is tell that your child is having type 1 diabetes if she has it. So that is what I practice. Yes. So yeah. Is there any more questions?
Yeah, 2 more questions. That is, one is related to diet. Is it okay to consume fruits by diabetic patients? If so, can you suggest some fruits or fruit juice which can be taken by diabetes mellitus patients?
Okay, fruit is a very good option for diabetes patients. It has got a lot of additional benefits like cancer prevention, a lot of antioxidants are there. So it has got a lot of good things, but then you need to exercise a portion control of the foods we take. So you can ideally go by the glycemic index of the fruits. If I'm not wrong, I'm not a dietitian, so ideally a dietitian should be answering all these questions. So probably you can go by the glycemic index, and if the fruit is having a very high glycemic index, probably you can take that in moderation. But you can always take, a diabetes patient can take all sorts of fruits, and make sure that you don't consume a fruit along with your main meal. So that can can cause a spot in your blood sugars. So if you're taking your fruit after a gap, say for example, if you're taking your lunch at 2 p.m. and then you're having your fruit at 4:30 p.m., then it will not usually cause a spike in your blood sugar, and it is rich in fructose and in fiber. So it doesn't usually give a very high spike in your blood sugar. But if you're taking it along with your main meals, then probably it can cause a spurt in your blood sugar. And what was the second one? So examples of some low GI fruits, I can tell you some berries. Don't go for dried fruits because that can cause a spike in your blood sugar. Go for the berries, and don't go for fruit juices because it doesn't give you any fiber. It doesn't contain fiber. Once you do it, you put it in the blender, then you lose all the fiber. So don't go for fruit juices. Go for the original fresh fruits, and it's always helpful because it has got a lot of benefits, and it is actually advocated for diabetes patients.
And the last question is about the alcohol consumption. That is a relationship between alcohol consumption and diabetes mellitus, whether we can have or is there any specific quantity?
Okay, so again, I'm not an expert because our dietitian every time does a patient education program, she gets a question on alcohol. So ideally, you shouldn't be consuming alcohol, but that is not going to happen in our city. So probably you can consume alcohol. There is also exercise, portion control. You need to have moderation if you're taking alcohol, and make sure that you don't consume alcohol on an empty stomach. It can cause a spike, or it can cause a low sugar. So keep your candies and your glucose tablets in hand if you're taking alcohol, more than in moderation. If you're using it in moderation, it won't it won't be that, what should I say? It won't be that worse. But then if you're using it in more than moderation quantity, I don't know. I can't tell you an amount up to what is like moderation, because you have a lot of products available with different alcohol content. So it all depends on what is the alcohol content which is there, and also use it in moderation. And you need to you shouldn't be using it on an empty stomach. So that is a take home message. Yes.
Thank you, ma'am. Participants, is there any more questions from the participant side? So I think only that much questions from the side of the participants right now. Over to you, Samiha, ma'am.
Feedback from the participants radiates that the session was splendid, knowledgeable, and on behalf of the participants, I'm taking this opportunity to thank both the speakers, Gopika ma'am and Veni ma'am, and also Remya ma'am and Resmi ma'am for the effective introduction and moderation. Thank you all. Now, it's time to announce the winners of e-leaflet competition, which was held among the pharmacy students on the topic Access to Diabetic Care for Better Tomorrow. To announce the winners, I would like to invite Dr. Kala D. Dr. Kala D, she is a self-motivated professional with a lot of ideas and living with a purpose on making positive impact on human life. She was a former professor and head College of Pharmaceutical Science, Government Medical College, Alappuzha. With great honor, I welcome you, ma'am. Over to you, Kala madam.
Yes, good afternoon to all. Am I audible?
Yes, ma'am.
Yeah. Now we are entering to the most awaited moment of the program from the students' perspective. As part of the webinar, e-poster competition had been conducted among the pharmacy students and pharma professionals. The response from the pharma community is stupendous. Congratulations to all the participants. Before announcing the result, I would like to thank all the participants and also the respective college for having entered the competition. With immense pleasure, I would like to announce the result. The third prize goes to Amrita Gopal, 5th year pharmacy student, Delhi College of Pharmacy and Research Center, Thiruvananthapuram. And the second prize goes to Catherine Mary, 5th semester B.Pharm student, Chemist College of Pharmaceutical Science and Research, Ernakulam. And the first prize goes to Blessy M. Joseph, PharmD students, St. Joseph College of Pharmacy, Cherthala, Alappuzha, and congratulations and best wishes to all the participants. Thank you.
Thank you, ma'am. I would like to invite Ms. Amrita Kobal, who has won the 3rd prize for e-leaflet competition. Amrita Kobal, please.
Hello.
Yes, Amrita. You are facing some network issues. Okay, we'll move on to the second prize winner, Ms. Catherine Mary C. Anthony, 5th semester B.Pharm, Chemist College of Pharmaceutical Science and Research, Ernakulam. Catherine.
Hello.
Yes, Catherine.
Thank you for, first of all, thanks for selecting. And on this Diabetes Day, let's take care more cautious and help to prevent our daily life. One of the most difficult situation in our day-to-day life, that is diabetes. So we can take preventions, and by knowing and taking notes from all of our very valuable speakers that have spoken today. So thank you.
Thank you, Catherine. Next, I would like to invite the first prize winner, Blessy N. Joseph, PharmD 6th year intern from St. Joseph College of Pharmacy, Cherthala, Alappuzha. Blessy, please.
Hello, ma'am. Am I audible?
Yes, yes.
Yeah, good afternoon all. It is a great honor for me to receive this prize. And I want to give my sincere thanks to every member of IGPA. And also the webinar sessions were really informative, and it was very useful and relevant. And thank you all for organizing such a nice event. So once again, thank you.
Thank you, Blessy, and congratulations to all the winners. Thank you, madam. Now, moving on to the official ending. It's my privilege to invite Dr. Ginny E.J., Professor, Department of Pharmacognosy, Daleview College of Pharmacy and Research, Trivandrum. She is also an executive member of IPGA. With much respect, I invite you, ma'am, to propose the vote of thanks. Over to you, Ginny, ma'am. Ginny, madam, are you there?
Maybe she is muted.
Ginny, madam, please unmute.
Good afternoon to everyone. Respected dignitaries of today's session, fellow pharmacists, dear students, I deem it a great honor and privilege to propose vote of thanks on this great occasion. Let me first of all start by giving glory to the Almighty God for making today's session a resounding success. Certainly, the last 2 hours were very useful, and all of us got opportunity to grab knowledge about various aspects regarding the theme. But Organizing such a wonderful informative webinar is a challenging task. This cannot be possible without a great preparation, with a wise working hand, supports from every corner, and blessings. Now, it's time to convey our gratitude to all who have extended their support to make this event successful. At the outset, on behalf of organizing committee, I would like to express my profound gratitude to our chief guest, Dr. Kanchan Kohli, convener, IPGA Women's Forum, for her presence, support, and motivation. Thank you, ma'am, for your valuable support and motivation. I express our immense gratitude to Dr. Sanjeev Dhawan, Director of Research and Development, Baxter Pharmaceuticals, Ahmedabad, for her unflinching guidance and encouragement rendered always. I would like to express our sincere thanks to Mrs. Gopika Krishnan GR, Head Academics, Jyoti's Diabetes Research Center, Trivandrum, for giving an excellent coverage and great overview of the topic and making the session very attractive. My heartfelt gratitude to Dr. Veni R.K., Assistant Professor, Department of Psychology, Jyotinivas College Autonomous, Bangalore, for your inspiring presentation. The depth of understanding and your ability to present the topic in such an interesting way. We are grateful for the time and effort you took to share your views and experiences at this event. I express my sincere gratitude to Dr. Kala D., former professor and head, College of Pharmaceutical Sciences, Government TD Medical College, Alappuzha, for announcing the e-leaflet competition results and also guiding us by giving lots of advice always. Mrs. Reshmi Chandran, Government Analyst, Drugs Testing Laboratory, Pune, deserves a special recognition for introducing our speakers and assisting them. I am grateful to Dr. Lindsay Thambi, Professor and Head, Department of Pharmaceutics, Chemist College of Pharmaceutical Sciences, Ernakulam, for delivering a remarkable welcoming address. A special mention to Mrs. Samiha Hassan, Managing Director, Med Academy, Thrissur, for anchoring the session and supporting all. A word of gratitude to Mrs. Dimya Gayatri S., Assistant Professor, Chemist College of Pharmaceutical Sciences and Research, Ernakulam, for moderating the session in a good manner. I am happy to offer sincere thanks to our President, IPGA Kerala branch, Dr. Satish Kumar CS, for his active guidance, support, and kindness. Sir, you have given your valuable time in fixing many sources related to this webinar. On behalf of organizing committee, I would like to convey deep sense of gratitude to our General Secretary, Mr. Dilip G, and Dr. Nishit NC, Executive Member, IPGA Kerala Branch, and Vice President, IPGA Southern Region, for their wise mentorship, encouragement, and assisting in each and every aspect. I would like to thank IPGA Women's Forum members from Tamil Nadu State, Dr. Vadivu and Dr. Vinodini C, for gracing the event by their presence. I would like to record a deep sense of obligation to our coordinator, IPGA Women's Forum Kerala, Dr. Mahalakshmi R, for her dynamic leadership, who have been the pillar of IPGA Women's Forum Kerala branch. Thank you, ma'am, for shaping us so well. I express my token of gratitude to all the members of IPGA, IPGA Kerala branch, IPGA Women's Forum Kerala, all the fellow pharmacists and other healthcare professionals who are always be the backbone of venture. Once again, I thank you all for your attention. Thank you.
Thank you so much, ma'am. Less and less of sugar means more and more of happiness. May you have a happy and healthy World Diabetes Day. On behalf of IPGA Women's Forum, I thank all the participants who made this session a grand success. Now, let's raise for the national anthem. Thank you all.